Good morning and good afternoon. I am Dr. Deborah Cohen, a volunteer moderator for the MAVEN Project, and I welcome you to today's session, Antibiotic Stewardship in the Outpatient setting, which is a joint session with MAVEN and Direct Relief. It's my pleasure to introduce today's speaker, Dr. Susan Jacobson, who recently retired from a clinical infectious disease practice as chief of her department at a Kaiser Northern California clinic. Her initial work in infectious disease was in Berkeley, California, as AIDS became a threat. Her practice included HIV care, clinical research, general ID, and antibiotic stewardship. And with that, Dr. Jacobson, would you like to begin?
Well, thank you, Dr. Cohen. It's a pleasure to give this lecture, and I want everyone to appreciate that there'll be a little bit fun periodically between various topics. These are the disclosures for MAVEN and that we're accredited for this talk. So we always have to have objectives, and here they are. And I think that one thing to think about is your local practice patterns, to think about how you are doing things wherever you are. And with one of the goals is to try and limit unnecessary antibiotic treatment. Using local antibiotic resistance, learning about it, and adjusting your antibiotics in the face of current resistance is also an important thing to understand. Of course, we want to minimize the risk of C. diff colitis, and that can be helped by antibiotic choice and potentially not using them if it's not necessary. And also, it's worth it to think about when you might need to use more. That will not be a major focus on this. We're going to be thinking a little bit about less. And also trying to help the patients know that antibiotics are not always better. That is not always easy, but worth trying. I want to direct your attention also to some places that are easy to reference and very quick. The Centers for Disease Control, the cdc.gov, has some wonderful, wonderful information quickly available. And guidelines from the Infectious Disease Society of America, IDSA, are also very easy to use. And recently, they have a new free app to put on your phone that I was playing around with. I'm not going to show you anything from it, but it's really fun and easy and free. So this is an image of outpatient antibiotic prescriptions across the United States in terms of antibiotic prescriptions per 1,000 population by state. And the deeper red indicates higher amount of prescriptions per population. So you can see that there's some really dramatic practice variations across the country. And that varies from less than 400 to over 1,000 per patient per year. And that is part of what's fueling some of the antibiotic resistance that's evolving. One of the important parts about the antibiotics is most of them are given in the outpatient setting. So what people are doing in the outpatient arena really plays a role both on the outpatient and inpatient. I won't mention the antibiotics that are used in animals, which is also an important part of antibiotic resistance evolution. We're not really in the position to talk too much about it or make that much difference, but it is an important issue nonetheless. And as you know, that evolving antibiotic resistance is a threat, and I'm sure some of you are perfectly aware of things such as methicillin-resistant Staph aureus or MRSA. So what do we think about using antibiotic stewardship, and what is the role in that in terms of total antibiotic use and also to help to decrease resistance? We want to think about what is the indication you're going to use the antibiotic? What are the patient parameters? the immunocompromised, chronically ill patient may need more antibiotics or may need less. What's the cost of the antibiotic? Some of you are in areas where an expensive antibiotic is just impossible. And of course, the antibiotic resistance we're talking about. So think about right drug, right duration, and right dose. So what do we think of as goals? We want to maximize the efficacy, improve the patient's safety, minimize the cost, extend the lifespan of antibiotics, and of course, decrease C. diff. And with that, doing that, are we successful at anything? Are we making any progress? Well, a couple articles here, multi-drug resistant or MDR, gram-negative infections decreased in a surgical situation from 2001 through 2008, going from 37% to 8.5% by limiting antibiotics and adjusting associated with local activity. It also decreased, antibiotic limitation decreases the risk of developing C. diff, which is obviously something we really want to do. C. diff can be challenging to treat and certainly challenging to experience. So thinking about when you might need to use less, coughs and colds, obviously, bronchitis, pneumonia, UTI, diverticulitis, and cellulitis, we're going to focus on here. There are many other things that we don't really quite have time to deal with. I'm not talking about STDs, and COVID will not be part of this conversation. And HIV, TB, drug-resistant organisms are not a specific talk. So this is some slides from the Centers for Disease Control. I think they've changed them a little more. This was from a little while ago. I looked in preparation for this talk, and these two are not there, but some other ones are that look very nice. And these can be very helpful in your exam rooms or and helping patients not feel like they need the antibiotic. On the left, what's got you sick, common respiratory infections, and just reminds people what is the cause. And the indication, maybe antibiotic is not needed for your sore throat. Now here it says COVID-19, are antibiotics needed? No, antivirals might be, but not antibiotics. And so these are a couple things. Both of these are simple images. You can print them out from the CDC website if you want to put them up somewhere. So let's move on to some specific topics. This first one is bronchitis and pneumonia. So what is bronchitis? It is an inflammation of the large airways. Thinking about it, not necessarily as an infection, it's an inflammation. It's pretty common. Maybe 1 in 20 adults get it every year. It is the 9th most common illness reported annually by physicians. Well, that's probably when the person comes in with a cold, you might call it bronchitis rather than a cold. I like the notion of airway sunburn, and that's my term. And it's a little bit like when you've got a sunburn on your skin, that's not an infection, even though it's red and it's a bit inflamed. But it's really that the airways are irritated. And what's happening is that epithelial cells are desquamating and denuding. And there's a lymphocytic cellular infiltrate. That does not mean that that's a serious bacterial infection. And obviously many things are causing it. Influenza, parainfluenza, RSV, coronaviruses, adenovirus, rhinovirus, bordetella pertussis, whooping cough, mycoplasma, and chlamydia. And some of these have absolute antibiotics usefulness. Pertussis, for example, you don't get better with azithromycin, but you decrease the transmission of pertussis to somebody else. And for mycoplasma and chlamydia, yes, you do get better with it. but your parainfluenza, no. How do we know that? Because antibiotics are given very frequently for bronchitis, and there might be settings where, chronically ill patient, okay, whatever. But here are some placebo-controlled trials that have looked at whether randomized antibiotic made a difference. Now you can see that the years on these are a little while ago, but many antibiotics have been tried: doxycycline, trimethoprim sulfa, erythro, and then most recent, not all that recent, azithromycin, which showed no benefit over low-dose vitamin C. And so I think that thinking about antibiotics as a benefit for acute bronchitis is basically no. Now, what did help bronchitis? Well, obviously trying to prevent influenza with vaccination and COVID with vaccination can cut down the risk of catching or suffering through a bronchitis. And then bronchodilators can make a difference. If you use an inhaler with bronchitis, there is about a 50% decrease in the chronic cough. That doesn't always work for everyone, but it can make a difference. Using expectorants can also help. That is helping the phlegm remove. And then ipratropium bromide is currently also recommended. Bottom line, less antibiotic, other treatments can make a difference. So how do we tell the difference between bronchitis and pneumonia other than getting the x-ray? Well, there's obvious features on the physical exam that will help you. The vital signs, fever, obvious temperature, heart rate over 100, the absence of focal consolidation will make you much more comfortable that it's bronchitis. And the elderly may not be typical presentation. They can certainly be a little slower to appreciate this. And the presence of purulent sputum, coughing up crud, doesn't necessarily mean that you have pneumonia, and is not a predictor of serious bacterial infections. So why do we care about this? Partly because it's a very common illness. So there is a HEDIS measure, and some of you probably are working in organizations where they track what you do. Antibiotic overuse in this situation can increase the risk of bacterial pathogens, and it costs a lot of money. We're not going to spend a huge amount of time on community-acquired pneumonia, CAP, hospital-acquired, because that is on the inpatient side. The one piece on this that I think it's worth some of you thinking about, and some of you possibly use, is ceftriaxone, which can be given in the outpatient setting for someone with early pneumonia, and may help that patient that you are not quite sure if they need to be hospitalized, and instead give them an initial dose of ceftriaxone, and then continue other antibiotic, whether it's doxycycline or azithromycin or levofloxacin. We'll talk a little bit about the quinolones in the future. But I'm not going to go deep into the rest of this slide. It's much more related to the inpatient side. But one thing in terms of thinking about pneumonia in the outpatient setting is that a 5-day treatment is frequently adequate. So let's think about what is an antibiogram. That is, what is that boring little graph that shows, the relative resistance in your community? Well, it is a collection of data for cultures and sensitivity from a given area. And depending on where you are working, whether it's a very small local clinic or whether it's part of a larger organization, you may have a printout that talks about what's the prevalence in your Staph aureus, for example, of MRSA, or your E. coli. What is it like in terms of sensitivities to trimethoprim sulfa. And it is really helpful to know what's going on locally, because your empiric choice of antibiotics is made simpler when you know locally what is typically circulating. And if you think back to the map I showed of the antibiotic utilization, I am sure that there's significant differences nationwide in terms of drug-resistant organisms because of the burden of antibiotic utilization. And foreign travel can affect whether a person's is carrying a drug-resistant organism. I've been learned this a fair number of times on people who've come back from frequently Southeast Asia, but not just, where they have an unusual gram-negative rod urinary tract infection on the slide. Where did this one come from? And what can happen is that people get colonized in the gastrointestinal tract with a pathogen that in and of itself isn't causing any trouble unless you get symptoms such as, and it can seed into the genitourinary tract. That can affect preoperative antibiotics and can make a difference in various situations. Also, people can be exposed abroad to other organisms that you might not normally expect in your area. So let's move on to UTIs. And one of the things about urinary tract infections is, how are you going to define that urinary tract infection? And is asymptomatic bacteriuria, that is white cells in the urine without symptoms, a UTI? And it's really important to be clear about that. Some places they will just do a urine culture without a urinalysis, which is, ridiculous, because you don't know if the bacteria in there are causing any inflammation. So one of the, and there's a very nice piece on the IDSA app, guideline app, talking about asymptomatic bacteriuria, and goes into some great details on it. So there are tiny situations where asymptomatic bacteriuria may make a difference, largely in pregnancy, and sometimes pre-procedure for a genitourinary procedure. But in general, you don't really want to know if there's bacteria in the urine unless there's signs or symptoms of a UTI. So, urgency, frequency, dysuria are all very helpful. Suprapubic tenderness and incontinence at times can be playing a role. Fever and leukocytosis in the setting of UTI symptoms can be, reflect that UTI and or pyelonephritis. And the diagnostic testing, pyuria, absolutely, white cells. Now, if somebody has an acute leukemia, they may not have white cells, but I think that it's a little bit unlikely that that person would be in your clinic with UTI symptoms. And so really think about in terms of your diagnostic testing, the white cells in the urine in addition to the positive culture. And with that, what is the best empiric treatment? That also depends upon the environment that you're living in. The IDSA current guidelines are expired. They're writing some new ones. This is 2010, obviously a little bit older. The Septra DS-BID for 3 days definitely still exists for settings where there is not as much E. coli resistance. So many parts of the country, there is E. coli resistance. And in that setting, you can't go away with Septra. Macrobid, 100 milligrams BID times 5 days is holding up, and it has a relatively low risk of major side effects in this short course treatment, and is probably holding up. Fosfomycin is sometimes more expensive, for example. But I'm encouraging people to reserve it for the resistant organisms, the ESBLs and the VREs, which and fosfomycin obviously is a little bit more expensive. So why not Cipro? Why not Levaquin? Well, there's a few reasons for that. First off, there's increasing resistance to the fluoroquinolones, and they are the only anti-pseudomonal drug that's orally available. So that we're trying to hold on to them for those for those values. They also have side effects and drug interactions, and they particularly have a higher risk of C. diff, particularly compared to something like macrobid or Cetera. There are a couple other options that we used when I was working in Kaiser, and one of them is cefadroxil, which is a first-generation cephalosporin, and it's like Keflex, only it's just twice a day. So cefadroxil, 500 to 1,000 milligrams, or cefpodoxime, very handy, very convenient, well tolerated, and relatively less risk of C. diff compared to something like Augmentin, which is frequently used, but does have a higher risk of C. diff. If there's true anaphylaxis, okay, you can go use your Cipro or the nitrofurantoin that we talked about, or Cetera. And duration, how long? For beta-lactams, it is a little longer, 7 days, Cipro, Levo 3. For pyelo, complicated cystitis, a man with the pyelonephritis, definitely longer treatment. With the beta-lactams, up to 2 weeks. Cipro, Levo, a little shorter, 7. So I'm going to give you, that's all sort of, we're done with the UTIs. We're done with the bronchitis and pneumonia, and this is sort of some basics around infectious disease rules. And reviewing past cultures is really helpful. It is may not be most convenient depending on your organization, how your charts are available, and in particular, if you don't have prior records. But if you do, take a look, especially for the person who has the recurrent UTIs. You'll have a much better chance of knowing what they're chronically colonized with. And then, think about the person's size. I was reading recently that I guess 3/4 of Americans are obese now, or maybe it's not quite that much, but large. So big people need big doses. So, you can't use lower dose, so cefadroxil 500 milligrams twice a day to treat a UTI in a very large person. That might be a setting where in the outpatient world, the ceftriaxone 1 gram works very well. From an ID standpoint, we're definitely encouraging everybody to get an HIV test if never done it. Certainly anyone who donates blood has had their HIV test. And with effective therapy for HIV, we never want to miss it. Tuberculosis screening, we are not talking about TB, but as far as like basic rules, if somebody is foreign born, really do think about TB screening. That is where the vast majority of active TB and latent TB comes from. You can either do the skin testing PPD or an IGRA, QuantiFERON Gold or others. And it's very helpful. And someone with latent tuberculosis, that is the reservoir of active TB in this country. So helping somebody with latent tuberculosis go through latent TB therapy is worth it. And then lastly, particularly for today's talk where we're talking about antibiotics, really think about whether a penicillin allergy is a true allergy. Typically, someone who's tolerated cephalosporins, you can go ahead and use the cephalosporins. So now that we've had that little break, let's move on to diverticulitis. And this is an area, and the reference for this is the Johns Hopkins Pocket IT, the ID antibiotic guide. And that's a handy guide as well. You do have to pay for that one, but I found it very helpful to have it in my, on my phone when I was in clinical care. And keep in mind that the treatment for diverticulitis is based on largely retrospective data, not major prospective trials, and I'll show you one soon. It is also a relatively common diagnosis in the outpatient world, 8th most common. And I'm sure you all know what the symptoms are: left lower quadrant pain, intermittent or constant, fever, altered bowel habits. And if it's mild and people are tolerating their oral intake, they don't have any other significant comorbidities, you can consider outpatient treatment. And how long would that need to be? Relatively short, 5 days. Amoxicillin, clavulanic acid, Cipro plus metronidazole, or trimethoprim sulfa plus metronidazole. And on the dosing of metronidazole, it has actually quite a long duration of action. So although it frequently will talk about it being Q6 or Q8, twice daily is fine. And from a tolerability standpoint, it is absolutely better. So Cipro, metronidazole, both BID, or trimethoprim sulfa, metronidazole, BID, is giving you good coverage for both anaerobes and gram-negatives. And both of those decrease the C. diff risk compared to augmentin or amoxicillin clavulanate. What about no antibiotics? This was an intriguing article in the Annals of Surgery. An open-labeled randomized trial of 480 patients had CT confirming uncomplicated diverticulitis. They were randomized to either oral augmentin versus pain management, and they had similar rates of return to the ER, 6.7 versus 7%, or hospitalization, 6 with the augmentin and 3 with just pain management. And that's really intriguing, so that you may or may not need a very potent antibiotic. Although I have to say, you have to be careful about that, because this is a study where people did have a CT scan that confirmed that it was uncomplicated rather than just empiric in the clinic. And more things can be going on than you really know. There is no evidence for the classic dietary restrictions, so the no seeds, etc. Short-term reassessment is really helpful, and we look in 2 to 3 days. If somebody is worse, then you go on and get your CT and or admit. And if somebody does get better, and this is their first episode, you may want to repeat or do that CT scan or colonoscopy once they've recovered, to be sure there's nothing else going on, i.e. colon cancer or polyps. So with that, we move on to the next topic, cellulitis. What's the difference between cellulitis and erysipelas? Well, erysipelas, is red skin, I think is what that just means. And it classically is a beta hemolytic strep, causing a demarcation of that border, and is classically streptococci. And some of that is immune mediated, but also streptococci can cause rapid cellulitis. And what about needing to cover for MRSA? Well, thinking about Staph aureus versus strep, the speed of the cellulitis is important, in that the streptococci can often do that quick spread. And then for Staph aureus, why would you think that there's MRSA? Well, first, if somebody was known colonized, i.e. had a prior culture which was positive, or they had a screening test, a nasal screening test. If there's purulent drainage or exudate from a wound, it may be Staph aureus or maybe MRSA. And it's always helpful to culture in that situation. You may not know at the moment when you start treatment if it's MRSA, but 3 days later, when they come in for a recheck, you'll know what the result shows. And if there is systemic toxicity, then you may really need to cover for MRSA, maybe need hospitalization even. But not every person needs MRSA coverage. And that is really worth thinking about as you are staring at that person's leg. So what treatments are we going to use? Well, we talked about the rapid onset with erysipelas and strep, and cefazolin, or in the clinic setting, cefadroxil, like I mentioned, which is like the twice daily Keflex. And that actually has good coverage for Staph aureus, as long as it is not MRSA. In addition, dicloxacillin can be used in the clinic setting as well. Although the cephalosporins, first generation cephalosporins, are often better tolerated than dicloxacillin, which is a 4 times a day drug. Now, what if you think if there's MRSA? We talked about the things for screening. We're not going to use intravenous vanco in the clinics. You might be able to get by with linezolid, but it's pretty expensive. What if you give them doxycycline? That has reasonable activity against MRSA. Trimethoprim sulfa has reasonable activity, but not so much for strep. You can use clindamycin, but it also has develops resistance to the MRSA, and it presents a significant C. diff risk. So if you see pus and you're going to see a patient back in 3 days, you may choose cefadroxil and doxy, for example, and you're culturing the wound, and a little bit later you'll know whether there's any MRSA. Once again, thinking about the size of the person, you also might think, well, maybe I should just give them a dose of ceftriaxone here in the clinic, have them come in for a check tomorrow, and maybe we'll have the cultures back in a short time, and using the 1 gram or even 2 grams of ceftriaxone in the clinic setting. And now I'm sure that many of you have used that, not all. It's definitely worthwhile to add lidocaine to it, because otherwise it's irritating, and it's an IM injection. So getting back to that penicillin allergy, is it real, or is it just intolerance? And we know that cross-reactivity is overestimated between penicillin and cephalosporins. If you don't have anaphylaxis, the cross-reactivity, for example, somebody had a rash to penicillin, the cross-reactivity with the first and second generation cephalosporins is about 1%. And with later ones like ceftriaxone, the cross-reactivity is nothing. And if it's even anaphylaxis, you can cautiously use a later generation cephalosporin. And one of the Kaiser's, San Diego Kaiser, looked at cephalosporins and found safe use in people with a history of both penicillin and cephalosporin allergies. So our degree of penicillin allergy is overestimated. And a family history of penicillin allergy does not mean that a person is allergic. And with that, we're going to go to one of our challenging issues, which is C. difficile colitis. Now, I'm very hopeful that most of you are not struggling with people with C. diff, but I doubt that it's gone. This is one of the reasons why I'm encouraging, and why when I was working with Kaiser, we were trying to avoid the fluoroquinolones with the high risk of C. diff. And if you look here, A little bit further down the slide, on the right side, the antimicrobial classes. The relative risk for clindamycin was 3.9 in terms of relative risk. And the fluoroquinolones was very similar at 4. Obviously, metronidazole presented less risk because it's used as a treatment for C. diff. Aminoglycosides on the list here are minimally risky, but every antibiotic has a little bit of risk. The other side effects from fluoroquinolones that are worth thinking about can be altered mental status, some of it related to dysglycemia, hypoglycemia. QT prolongation can happen in tendon rupture. There are also drug interactions. So thinking about frequently associated C. diff and antibiotics, this shows pretty similar information from before, from the earlier slide. And I think that we don't need to go into it too much. So basically thinking of fluoroquinolones and Clinda. So what are we talking about with C. diff in terms of treatment, and how do you get it? Well, first off, how does it come? Frequently, it can be in the environment. Now, that environment is not necessarily at your house, unless someone has had C. diff, and that particular bacteria can colonize various parts of the toilet, of the handles, your sink. It can persist in the environment quite easily, which is one of the reasons that it's been difficult to fully eradicate it in hospital situations, because those hospital rooms need to be cleaned every day and very effectively. And settings where there is a fair amount of C. difficile in a community, in a hospital setting, can then set the stage for people acquiring C. diff in their as asymptomatic carriage. Just like I mentioned, traveling abroad, you come back with a resistant organism. Well, you go into a hospital, and places where they're struggling with C. diff, you may get asymptomatic carriage. That particularly increases when people are in long-term care, and also people who've been hospitalized. And then what triggers the C. difficile colitis can be the antibiotics. So someone's colonized, and then they get an antibiotic, and then the diarrhea begins. Making the diagnosis with a stool test is absolutely critical. And you may or may not need to repeat the test or do a colonoscopy to clarify if it's still present, or if there's any other pathogen. In terms of treatments, we've largely given up on metronidazole, unless you really are in a financial situation where it's the only way you can do it. It is less effective, and it is not as well tolerated from the GI symptoms, from the metallic taste, etc. But financially, it's less expensive. And for a mild disease, you might consider it, but both fidaxomicin and oral vancomycin are both the recommended treatments. Again, looking at the IDSA app on their C. diff, they do talk about both of them as being reasonable doses. In terms of duration of therapy, fidaxomicin versus oral, I'm not going to get into all the details there. Recurrent disease is often very difficult, and whether treatment is certainly retreatment with metronidazole is not recommended. Retreatment with either Vanco or switching to Fidaxo may make a difference. Prolonging a therapy may make a difference. Looking for any other reason why the diarrhea is persisting is also really important. There has been some success with FMT, that's fecal transplant, stool transplants. It's been a bit of a difficult thing to prove. The settings under which the clinical trials occurred, it's a bit complicated, and I'm not going to go into any great detail. And I'm going to end with a kind of a fun thing. As I was just reviewing cdc.gov recently for something else, I decided to look at outbreaks. This is just a quick snippet from some of their outbreak listing. I'm sure many of you have heard about the McDonald's onions outbreak in October. Well, this was an E. coli outbreak, and it was from the onions. It wasn't from the beef. A couple of months earlier, there was an outbreak of listeria related to sliced meats. And listeria is classic pathogen that can can kind of grow in cold enrichment, and meats, deli meats, it can often be sitting there for a long time refrigerated, and it can set up shop. There's been a little bit more measles in the United States. Basically we were a measles-free country for quite a long time, but there's been some outbreaks this year. Not so many, only 277 cases have been documented. 40% were hospitalized. They do an update every couple of weeks on the website, and that has to be thought of in perspective, because there's a fair amount of measles circulating globally, and so you're much more likely to be have a patient with a new rash if they've come back and presumably they were inadequately vaccinated prior to travel or in their childhood. Most of the measles outbreaks in the States were related to people who were very small, and I think that they were not vaccinated. Obviously, the coronavirus disease has been an outbreak with us since January 2020. Currently, it's doing pretty well. And if you don't know, or your patients, they can order 4 free COVID tests that are available for each household, and you do it online at the cdc.gov site. In addition, there's international travel health notices in terms of outbreaks, which I came across: global dengue, measles, some others. There have been a couple cases of dengue circulating in the southern states of the United States, where we do have the mosquitoes that will provide the way that dengue can spread. Here are some references. And particularly if you're looking for some free CME that you learn a little bit about the antibiotic use, there's this progress and opportunities from the CDC. It is still available, and it's free CME on some of these topics. The IDSA practice guidelines were pretty nice, particularly the mobile app. You can always look for outbreaks and travel advice from cdc.gov. And with that, I'm going to show you a nice picture from Yellowstone and get any questions that you might have.
Thank you very much, Dr. Jacobson, for that really clear and practical presentation. That was great. There are some questions. Would you like me to start?
Sure.
The first one is, how does consumption of animals given antibiotics impact us?
That's a good question. The animal is colonized with a resistant organism. The animal, presumably you're not eating raw steak tartare, nor is, if you are eating steak tartare, the organism isn't in the meat per se, it's in the GI tract. And unless there's contamination at the food preparation, you're probably not getting it. But what resistant organisms in the animals do is that in their fecal dung, that can spread to the fields that are nearby them. That's certainly been how some of the salmonella has gotten into various outbreaks and other situations. And the resistant organisms can also be acquired by people working with the animals in butcher shops and in food processing. So I think it's more through the exposure of people handling the animals than you eating the animal.
Okay, thank you. Both the elderly and CLL patients often do not present with fever. I think this is in regards to bronchitis, perhaps. So do we treat or not?
I think that's a very good question. And I think to some extent, it depends on your particular patient. If you have a patient that you know well, and you've treated them previously, and you understand that they're frequently not recovering, I think you may consider treatment with antibiotic. Certainly the lack of, and if you're trying to decide whether there is or is not pneumonia on that patient, and you have access to x-rays, it's certainly reasonable to do the x-ray. A person with CLL, certainly with immunocompromise like that, you probably are going to use, more likely to use the antibiotic, and also keep a closer eye on them, have them be rechecked, for example.
Okay. I was told not to look at UA when determining if a patient has a UTI because there may be false negatives for nitrites or white cells. Is that true?
No.
Okay.
Think a little bit. Let's put a Foley catheter in there as well. We didn't go into any great details, but if somebody's got a chronic Foley catheter, they're going to have some white cells. And that may or may not indicate whether the person has a UTI. In that situation, you have to look at more serious symptoms like fever and malaise, and probably may have suprapubic tenderness. But just looking at the urine culture alone will not provide information about whether there's symptoms related to bacteria in the urine. And bacteria in the urine is so common that without some symptoms, you're not necessarily going to need to treat. There's lots and lots of talk about that. And the false negative on the urinalysis may happen if somebody has acute leukemia and they're in the hospital. That situation we're really not focused on here. We're really talking about the outpatient setting. There may be other reasons. If someone has some dysuria, they may have an STD, not a UTI. So I would disagree with don't look for the white cells in the urine.
How do you know if an organism is susceptible to fosfomycin? It's not reported on the urine culture.
Oh, that's a good question. I would probably assume that it would be, but you may want to check with whatever laboratory you're getting the report from. And as I talked about, trying to reserve those for the resistant organisms. You may not be losing your fosfomycin use if you don't use it very much. So check with the lab if you can.
Okay. What is the most narrow spectrum antibiotic that can be used for a pan-sensitive UTI? What about for cellulitis?
I would say cefadroxil is handy for both. First generation cephalosporin, effective for cellulitis, for staph and strep. pretty narrow therapy and well tolerated. For cellulitis and the other, for UTI, it's not something that there's a huge amount of large published information about using first generation cephalosporins. In the clinical experience we had in the Kaisers that I worked with, it was remarkably effective and was so well tolerated that it made people get through a UTI course without too much trouble. I may consider the macrobid that we talked about before, the nitrofurantoin 5 days for UTI, as probably maybe your best go-to for UTI from a common, use.
Okay. For UTI, do you recommend a test of cure or base your follow-up on clinical response? I think this is concerning a concern of resistant pathogens.
I think what I would do is on the individual patient, if it's a simple UTI, a young woman or a man, particularly young women, simple UTI, did a culture, I definitely encourage you doing cultures. Someone comes in with presumptive symptoms, or even calls in with presumptive symptoms. I'm a fan of culture and treat, not just treat, and then if it fails. But say you've treated, and it was not a resistant organism, I would not test a cure. However, if this was a highly resistant organism, and you really had to work at trying to treat it, whether that was on the inpatient side or outpatient side, you may want to relook at chronic colonization and see if it's still there in a couple weeks after treatment.
Okay. Up to date says no need for antibiotics in simple diverticulitis. Have patient go on a liquid diet. I did this and patient improved on her own. Does the liquid diet starve the bacteria?
I'm so glad that you used up to date and that the no antibiotics is beginning to gain credence. It's relatively recent. I don't know that, I doubt that the liquid diet starves the bacteria. And I think that a simple diet, whether it's liquid or whether it's soft diet, I'd have to look at the clinical research, and that is a new evolving strain idea in diverticulitis that we can get by without antibiotics. And I mentioned that a surgical study that showed that it was effective, but starving, I think they probably got enough food somewhere in there.
Okay. There's a comment on the chat, I believe, from a gastroenterologist. Just in case is not an indication for antimicrobial therapy. Children treated with antimicrobial therapy have a marked increase in inflammatory bowel disease.
Oh, I really appreciate that. That's a really clear comment. And the just in case comment, I think, is also used frequently for many people who have their URIs, they need their antibiotics, this and that. Just in case is something that's important to keep, not just for peds, but for adults. Thank you.
And the additional comment with that part of the chat is a liquid diet prevents formed stool from traumatizing the site of diverticulitis.
Ah, very good. That's a good reason for your, yes, no, we don't want any trauma from your formed stool. There we go.
Okay. What is the best antibiotic regimen for a pregnant woman if bug is pan-sensitive?
Well, the first generation cephalosporins are fine. Depending on the state of pregnancy, you can use trimethoprim sulfa. You don't do it late in pregnancy. I would have to look up nitrofurantoin, the macrobid. I think it's fine in pregnancy, but I would actually have to look it up, which I won't do right now. But that's a good question. and first generation cephalosporins are very well tolerated.
Okay. Does metronidazole gel intravaginally instead of PO for BV better for antibiotic stewardship? My colleague says it doesn't matter, the gel gets absorbed.
I don't know. That's a new one. That's new on me. I'm not sure, but in terms of tolerability, trying to decrease the oral metronidazole to twice daily rather than 4 times daily is definitely worth it.
Okay. And you recommend albuterol for cough due to acute bronchitis, even if no wheeze?
That's been seen on some of the studies that we're looking at non-antibiotic treatments. The ipratropium bromide might be even a little more effective, but either of them in a sparing antibiotic and decreasing inflammation. Now, I think the other key issue here is trying to help expectorant be helpful so that the inflammation, the desquamating cells off of the bronchitis are easily coughed out. So that is also a real helpful use, and that plus plenty of liquid so that you're coughing up the inflammation.
Okay, 2 more quick questions. Could someone with bronchitis feel better from azithromycin or doxycycline simply due to their anti-inflammatory effects, even if it's not due to bacteria?
Perhaps, but keep in mind that some of those clinical trials done long ago really did not show benefits of antibiotics versus standard of care at the time in terms of clinical improvement. The other piece to keep in mind is that people may feel better with treatment because of the placebo effect. And that is one of the challenges in terms of trying to not give an antibiotic as you're diagnosing someone with bronchitis.
Okay, thank you. And the last question, second to the last question. I was told if you use fosfomycin, we need a test of cure, correct? And if so, when? 1 week after?
Well, they might be requiring a test of cure for fosfomycin in your location, and I will defer to wherever you work. Because we really do want to minimize evolution of drug resistance with fosfomycin, because it is used for resistant organisms. And if so, I would certainly think about doing it not earlier than 1 week, maybe 1 to 2 weeks. And it is for lower UTI. It isn't for pyelonephritis.
Okay, great. And this is the last question. Jermaine, do you want to go ahead and talk? I've unmuted you. Jermaine, are you able?
Yeah, here I am.
Okay, great.
So sorry. It was an excellent lecture. My apologies. I think that was by accident. I don't have any questions. It was
Okay.
very thorough, and I really appreciate the information. It was wonderful.
Oh,
Thank
Okay.
you.
All right.
Thanks.
Okay.
Sorry.
No problem. Thank you for being here. Okay, I think thank you so much, Susan, for answering so many questions. You did a great job. And I think with that, we will stop recording and close the presentation. Thank you, everybody.